Good morning once again, students. This is chapter 26 on eating disorders, and let's get right into it. When we speak about eating disorders, what are we talking about? We're talking about abnormal eating patterns, maybe eating too much or eating too little. Uh, so you're taking either too much calories or too little calories. These individuals usually have a preoccupation with food and weight. And this usually is accompanied by anxiety, guilt, or low self-esteem. So there is these three components that usually accompany the eating disorder. Now, it can occur with an individual not feeling like they want to eat at all, or a dislike for food, which we see with anorexics, or with binge eating or bulimics. They eat a lot of foods and they're not satisfied. Okay, and these usually can result in physiological imbalances. For example, with electrolytes and medical issues, like, for example, hypertension or the dysrhythmias. How do we usually treat these? With therapy like SSR and SSRIs. What are the benefits of proper eating? Well, you're maintaining your energy levels when you eat. Also, food is needed for cellular repair, etc. All right, and you're maintaining your weight. So, who usually experiences eating disorders? For example, like anorexia. Well, white, affluent, well-educated adolescent females or young adult females are usually the ones that become anorexic. All right, and reasons for the increase in eating disorders in the male population, however, is a little different. We see males who are focused on athletics, on certain sports. And the sport requires stringent weight categories. For example, like gymnasts or wrestling. That they do. The wrestlers usually might have a more stringent weight categories, and so this requires lean muscularity, lean body mass, and we could also see this with models, and also with the homosexual population. They like to remain thin. And sometimes the younger generation, millennials, who want to get into their skinny jeans, you'll usually see uh, the eating disorders with individuals like that. Um, Factors contributing to eating disorders are diets that become out of control. Sometimes people diet and they look good and they get compliments, and then all of a sudden, they start having eating disorders. Genetics, you might have inherited genetic eating disorder. Onset of puberty, uh, major life changes like stressors or and anxiety with poor coping skills might play a part. Family dynamics, meaning a family which is over controlling and overburdening on their children, and they require perfection, and they want their children to get high grades. So these also this can create a problem with anorexia, especially because these children are that's the only thing that they can control is their eating. Everything else is under the control of by their parents. The parents are usually the ones that are controlling that. Sociocultural emphasis on slimness, when the culture requires that the individuals maintain thinness, and peer pressure is also a factor where children tease each other or etc. Theories explaining eating disorders. We already mentioned the out of control uh, diet, okay, and genetics. We also mentioned that. It's hereditary impairment in brain function in the hypothalamus, which regulates um, the eating. Um, Theories explaining eating disorders on slide 8 continues. Um, Sociocultural theories say that disorders are more prevalent in countries with adequate food. Maybe there's too much eating, etc. And sex roles for expectations for women, that women should be thin and beautiful. And again, we mentioned the family-based theories where the family is too enmeshed with the children and they're very overprotective and they display poor boundaries with the kids. They don't allow them to be children. They don't allow them to be kids and to grow. So they're overprotective, over controlling, and rigid. And they also display perfectionistic tendencies. On slide 9, we have uh, a picture of a young lady who thinks that she looks too big. When she looks in the mirror, she's measuring herself and feels that she's too fat. There's a picture of a Renaissance picture uh, of some women, and as you see, these women are a little bit plumpy because back in Renaissance in the 1600s, plumpiness was beautiful, considered beautiful. Now today, plumpiness not so beautiful. But up until the 1900s, from 1600s to the 1900s, it it was okay to be have a little meat on your bones. All right, so let's look at anorexia nervosa, slide 10. This eating disorder is these individuals rather usually have a distorted body image. They think that they look fat, they're too big, even though they may be thin as a rail. They're very thin, but yet they feel they're fat. They're emaciated, but yet they think they're fat. And they have this intense fear of becoming obese. So they take in very little calories and or they purge. If they do take in, they feel they've taken in too many calories, then they'll purge. A distinction with anorexia is a BMI, a basic metabolic index of under 17. Okay? With bulimia nervosa, we see binge eating. That means that they eat a lot and then they'll go and they'll throw up. Now, we can also see this with anorexia nervosa, but not as common as with bulimia. So with bulimia, we have binge eating and purging and a BMI of over 20. Okay, so there's a distinction between also the BMIs. You have to look at it. In order to diagnose, you look at the BMIs. Now there's also binge eating disorder, BED, which we will cover. We'll look at that. Okay, so on anorexia nervosa, slide 11, you can follow with me. So these patients, again, they consume very little food, but they can also become obsessed with food or obsessed with cooking and stuff like that and talking about food, but still it doesn't matter that they will not consume a lot of calories. Now, Giada, who is a cooking chef, she has her own show. If you've ever seen her, I believe that she's an anorexic. Even though she has a cooking show, I think she falls in this category. She's skinny, but yet she cooks and cooks and cooks and loves food. All right. So getting back to anorexia, two types. You have the restrictive type that just restrict the caloric intake, and then you have the binge eating purge type, which if they do eat too much, they feel like they've eaten too much, then they will purge. They can stick their fingers in their mouths or their fist and throw up, or they can use laxatives, diuretics, and enemas. And again, with the anorexics, we have that family history with the family dynamics being poor personal boundaries, and the children are usually very compliant and obedient, and they have high academic achievements, and they are perfectionists. Now, characteristics of bulimia. All right, so with a bulimia, now you have a rapid ingestion of food. These people eat a lot of food, and then they may feel guilty, feel ashamed that they ate so much, so they'll stick their fingers in their mouths or the fist in the mouth, and then they'll throw up. Um, they'll induce vomiting. Or they can exercise or use laxatives, enemas, or diuretics, again, just like the anorexics. There's a non-purging type, which use fasting and excessive exercise. If they've eaten too much, they feel like they've eaten too much, then that's what they'll do. Clinical client with bulimia, uh, again, it involves the behaviors involve uh, food and weight management. They overeat, and of course, then they try to manage their weight by doing different things. They usually you usually see a young college-educated woman who, again, is a high achiever, and they tend to be passive, dependent, and unassertive. Okay, there's usually an alcohol or substance abuse problem associated with it. Slide 15, we have binge eating disorder, and these individuals will consume large, large amounts of calories, and they might have more of a sedentary lifestyle. Uh, and the recurrent binging will lead to obesity. They usually wind up being very fat, and they have guilt and shame associated with the fact that they eat a lot, and they have psychological distress. The physiological consequences of starvation would be amenorrhea, lanugo hair, hypertension, bradycardia, hypothermia, constipation, polyuria, and electrolyte imbalance. The most important one of these is the electrolyte imbalance, because that may prove lethal or fatal. Why? Because you have a tendency then to have cardiac dysfunction, like arrhythmias. Okay, so that's why it's very important to monitor blood levels with these clients. Comorbidities with dual diagnosis with these patients. Studies show and associated depression, anxiety with eating disorders. Okay, so there's a correlation between them. Between 25 to 50% anorexia nervosa have anxiety. 33% of the clients with binge purge behavior have alcohol or substance abuse. Binge purge behavior is usually the bulimia. And bulimia also coexist with depression 30 to 36 to 70%. And we mentioned substance abuse. A lot of bulimics are substance abusers, 18 to 33%. And they also might have some personality disorders. Treatment of eating disorders. People with eating disorders rarely seek help. And if they do seek help, they usually do not they don't maintain the interventions, so they may never seek or receive any interventions at all. They're not motivated for change, and they often leave treatment before they finally get any good help. Some recover spontaneously, whereas others can have it into their until they're old to become seniors. Multidisciplinary care for patients with eating disorders, individual, family, and group psychotherapy, okay, behavioral modification therapy, cognitive behavioral therapy is also good, and antidepressants like Prozac, 60 milligrams would sometimes be used. And as a nurse working with these patients on a unit, you'd have to monitor their eating habits. So when they do eat, you would need to remain with them for 1 to 2 hours after, up to 1 to 2 hours after they eat, because this is to prevent them from purging out the food. Okay, and sometimes anti-anxiety medications can be used also. It can benefit them. Multidisciplinary care for patients with ED. We already mentioned the different types of therapy, the behavioral family therapy, behavior modification, and weight gain. Weight gain would need to be monitored. Refinement of weight gain program and introduce of non-food related issues and cognitive restructuring. What does that mean? It means that we would maintain and control over food. It will be gradually returned to the individual. Okay, so we would focus on any family issues with the client and their family, and then eventually then give back control of eating to the individuals. But up until then, we will not allow them the control over what they eat. We'll help them with that. We'll decide for them what is good in terms of what they're going to eat and not eat. Symptoms related to disturbances in nutrition and metabolism, at slide 21, dehydration, hypokalemia, cardiac dysrhythmias, as we mentioned before, dry skin, brittle hair and nails, frequent infections because the immune system is not getting the nutrients it needs to function, dental caries is another one. Dental caries because of the constant acids in the mouth when they throw up, and inflammation of the throat and esophagus, okay? And swollen parotid glands because they're purging, amenorrhea, and hypothermia. Okay, and slide 22, you'll see a very anorexic woman. You'll see the brittle nails, a picture of the brittle nails, and the acids have corroded the enamel of the teeth. Teaching points for clients with eating disorders. Nurses offer the following suggestions to clients with an eating disorder and their family members. So the family should provide unconditional love, and they should focus on the individual rather than on the eating disorder. Okay, they need to focus on that person's well-being and not so much the disorder. They give the client the power to make decisions and facilitate changes in matters other than food, not on food. They don't have a decision on that. You know, they'll get control over what they eat, etc. after they've shown that yes, they can comply with the treatment. All right, and next slide, 24. Desired outcomes, of course, would be that there would be some weight gain. Maybe 1 to 2 client will, a patient will gain 1 to 2 pounds a week, and then you have to have a care plan for that. Normal laboratory values and vital signs, etc. And the desired psychosocial outcomes would be that the individual will develop a realistic perception of body image, and will be able also to express their feelings, whether it's towards their parents, a disagreement with their parents, or conflicts with them. And the individual improves self-image and a sense of control over self and the environment. Okay? And I hope that that's been somewhat helpful to you, and thank you. Bye.